Well, good morning, everyone. This hearing will come to order. I want to welcome our witnesses and thank you all for being here. Small businesses, all of us know, are innovators, and particularly now in health care. Small companies are transforming medical care with new products, new services, and cutting-edge technology. And small medical practices are changing as well. They are helping us connect and serve a more mobile population. Telemedicine refers to patient medical care where the provider and patient are separated by distance. Although the adoption of telemedicine has been slow, it is increasing, and recently several medical organizations adopted model policies for its appropriate use. This technology offers the promise of connecting small physician practices with patients, other medical providers, hospitals, and areas that are medically underserved. Today, some small practices are finding it difficult to stay afloat due to the burdens of complying with the health care law and the cost of operating a small practice. Telemedicine may provide opportunities for these practices to broaden their reach and offer more accessible care to more patients, serve a larger geographic area, or consult with distant medical colleagues. Some have suggested that small practices can be the hub that connects a patient's health care team. But small practices can encounter numerous barriers to telemedicine: the cost of technology, broadband availability, licensing requirements, and reimbursement rules from private insurers, as well as Medicare and Medicaid, may limit or delay the adoption of telemedicine. Today, this subcommittee will examine a topic that touches both health and technology, the use of telemedicine and its possibilities for small medical practices. We look forward to hearing from our distinguished panel of witnesses about this exciting convergence of medicine and technology. I'd now like to yield to Ranking Member Hahn for her opening remarks.
Where are the women? Oh, they're all here. I usually always say that with the witnesses, but this is a good crop of witnesses. Thank you, Mr. Chairman. Welcome to the witnesses. I look forward to hearing from you. And as the Chairman said, the coming expansion of telemedicine has the potential to increase access to health care to underserved communities, both in our inner cities and rural areas, and keep Americans across the country healthy and independent. Today's hearing offers us an opportunity to examine ways in which we can increase the use of telemedicine, especially among small medical practices. We know that if implemented correctly, small practices may be able to cut costs, connect with patients that would be otherwise out of reach, and improve patient care. Enabling doctors to better communicate with their patients has been shown to dramatically decrease hospital readmission rates and give patients peace of mind. Enabling healthcare providers to communicate with each other would mean expanded access to the latest treatments and the best possible care available. Unfortunately, questions surrounding reimbursement, licensing, liability, and the cost of technology have prevented many small practices from adopting telemedicine services. The technology we need is ready. However, our nation's healthcare system is not. In the coming years, we as a country will have to address how telehealth care is reimbursed, how and where doctors are able to practice remotely, and how to handle sensitive patient information. None of these questions have easy answers, and I appreciate every one of our witnesses for joining us today in hopes of shining some light on these and other issues. I look forward to hearing from all of you and from my colleagues. Colleagues, where are they? I'm not here. As the telemedicine expansion continues, I hope we can work together so that doctors can provide patients with the very best care possible. I yield back.
Thank you. Before we start, there will be votes coming up at some point. We'll see where we are in the hearing, and worst case, we'll adjourn and then come back and finish. It's also our last day in session for 5 weeks, so there is a lot going on, and we'll kind of play this by ear a bit. If committee members have an opening statement prepared, I will ask that they submit those for the record. And also, we have some timing lights. You'll see them start out as green, turn yellow, and turn red. we certainly have some latitude when we do those, but it's just a guide for your 5 minutes. Our first witness today is Dr. Karen Rubin. Dr. Rubin is Senior Associate Dean for Continuing Medical Education and External Affairs Director for the University of Virginia's Center for Telehealth in Charlottesville, Virginia. Dr. Rubin is past president of the American Telemedicine Association, very appropriate for today's hearing. Welcome, Dr. Rubin. You have 5 minutes for your testimony.
Chairman Collins, Ranking Member Hahn, committee members, thank you for your invitation to testify regarding the opportunities and challenges faced by healthcare providers seeking to incorporate telehealth into everyday practice. I am the director of the Center for Telehealth at the University of Virginia and a practicing pediatric cardiologist. At our center, we connect patients at 128 different sites across the Commonwealth of Virginia for access to specialty care. Telemedicine or connected care is not a new specialty, a new procedure, or a new clinical service, but rather technology designed to enable the provision of healthcare services at a distance, whether it's down the road or across the state or across the country. 21st century telemedicine services can be provided live via high-definition interactive video conferencing supported by peripheral devices, or asynchronously using store and forward technologies, or using remote patient monitoring tools, keeping patients healthy at home. Telemedicine improves patient triage, reduces the burden of travel for care, enhances timely access to care, and saves lives. A few examples. Telemedicine helps us to treat acute stroke victims in critical access hospitals when every second counts. It allows us to manage high-risk pregnant women in their home communities, reducing premature deliveries. Through telemedicine, we provide sorely needed mental health services. We screen patients for diabetic retinopathy, the #1 cause of blindness in working adults. We monitor heart failure patients after discharge from the hospital to keep them healthier at home and in the workforce. Regardless of the delivery system, and in particular as we migrate from volume-based to value-based systems of care, telehealth supports patient engagement and self-management. As supported by extensive evidence, telemedicine improves clinical outcome and also lowers the cost of care. It is widely accepted that our nation faces a shortage of physicians and other health professionals, expected to worsen with our aging population, higher rates of chronic illness, and greater numbers of covered individuals. The use of telemedicine maximizes provider efficiency, but again, most importantly, is good for patients. Despite our country's multi-billion-dollar investment in telemedicine, broadband expansion, and health information technologies, efforts to promulgate continued integration of telemedicine unfortunately still remain stifled by 20th century federal and state barriers to more widespread adoption. Opportunities for small practices to adopt telehealth are extensive, depending on the credentials of the provider and the model they might wish to deploy. Primary care and specialty care providers can connect to their patients or to one another through video conferencing. They may offer clinical services through store and forward technologies, serve on panels for telemedicine services companies, and utilize remote patient monitoring in the home to manage their patients with chronic illness. Regardless of the model chosen, it's imperative that interested practitioners take into consideration all relevant federal and state policies and specialty society best practices. Significant challenges still impact telehealth practice, such as originating site restrictions on reimbursement by Medicare and varying degrees of reimbursement by state Medicaid programs and private payers. Last year, sadly, Medicare reimbursed less than $12 million nationwide for telemedicine-related services. A patient or provider's zip code should not determine eligibility for telemedicine care when, on the other hand, our Medicare and Medicaid programs spend many hundreds of millions of dollars annually on transportation costs. As an example, last year, our UVA program saved patients more than 4.8 million miles of driving for access to care, keeps patients local in their community. Equally challenging are variable state board regulations that have led to continued uncertainty for practitioners, confusion about credentialing and privileging regulations, lack of licensure portability, which is a deterrent to interstate practice, anti-kickback laws, HIPAA privacy and security regulations, evolving technology platforms, device interoperability, and health information exchange are all important issues to be considered, as is the cost of sufficient bandwidth. In conclusion, telehealth is a valuable tool to address the significant challenges of access to high-quality care, to mitigate workforce shortages, improve population health, and lower the cost of care. There are many opportunities for small practices to integrate telehealth into everyday practice. However, even for large healthcare systems such as our own, managing and navigating the complex legal and regulatory environment which impacts telehealth can be very challenging. Thus, it's imperative that we create and implement policies that foster certainty, high-quality, secure, and sustainable solutions that empower patients and providers and payers to adopt 21st century models of care. Thank you.
Thank you, Dr. Rubin. I'd now like to yield to Ranking Member Hahn for the introduction of our next witness.
Thank you. I am pleased to introduce Dr. Megan McHugh, Research Assistant Professor and Director of Health Policy and Implementation at the Institute for Public Health and Medicine Center for Healthcare Studies at Northwestern University, Feinberg School of Medicine. Dr. McHugh's research focuses on federal health policy and advocacy and has been awarded support by prestigious institutions like the Robert Wood Johnson Foundation, CMS, CDC, and the Kaiser Family Foundation. She holds a master's from the College of William and Mary and a PhD in public policy from the George Washington University. Welcome, Dr. McHugh.
Thank you, Chairman Collins, Ranking Member Hahn, and members of the subcommittee. I'm honored to have been invited to testify today. My name is Megan McHugh, and I'm a research assistant professor at Northwestern University. And my research and teaching focus on federal health policy and the impact of policy changes on healthcare costs, quality, and access. And the opinions that I'm going to share today are my own and not of the university's. First, I'd like to make 3 points. First, by adopting telemedicine services, small physician practices may be better prepared to participate and succeed in new models of care. The traditional fee-for-service payment system, which pays providers for each visit, procedure, or test, is an obstacle to achieving the triple aim of better health care, better health, and lower costs. In an effort to move away from the fee-for-service model, the Center for Medicare and Medicaid Innovation, which was created by the Affordable Care Act, is supporting the development of new payment and delivery models which reward providers for delivering high-quality, low-cost care. Telemedicine has an important place in these value-based purchasing programs. For example, under the bundled payment demonstration, providers have the flexibility and the financial incentive to care for patients using the best means possible at the lowest cost. And since some data suggests that telemedicine offers comparable care quality at a lower cost than traditional in-person visits, providing care via telemedicine is a natural choice. Given the momentum towards value-based purchasing, small physician practices would be well served by exploring whether and how telemedicine may help them provide high-quality care at a lower cost. My second point is that reimbursement and state licensing policies serve as barriers to the adoption of telemedicine by small physician practices. Medicare generally limits payment for telemedicine services to interactive audio and video telecommunications with real-time conversations where the original sites are located in a rural area. As a result, telemedicine accounts for a very small portion of Medicare services, as we just heard. However, through the rulemaking process, CMS has been gradually expanding reimbursement for telemedicine. For example, just this year, CMS changed the geographic criteria for originating sites, which will expand reimbursable telemedicine services to more rural Medicare beneficiaries. Although research on the impact of telemedicine on cost, quality, and access is very promising, the evidence, I believe, is not conclusive. And as a result, I believe that the gradual expansion of telemedicine coverage under Medicare is a sensible course of action and one that will produce a slow but steady increase in the number of small practices that effectively and efficiently use telemedicine. And a good first start, in my opinion, would be to extend coverage for telemedicine to all value-based purchasing programs like patient-centered medical homes and accountable care organizations. With regard to licensure, some state medical boards require telemedicine providers practicing across state lines to have a valid license in the state where the patient is located. And providers who want to practice across state lines must obtain an additional state license, which can be administratively burdensome. This burden may be greater for small practices, which are less likely to have support staff who can help them navigate this process. And my personal opinion is that the current medical licensure system is inadequate to address the growing practice of telemedicine. And there are several alternative models that could be considered, though each of them might raise some political and potentially legal challenges. And then third, any policy that expands the use of telemedicine should be carefully monitored. The academic literature on the impact of telemedicine is voluminous and still growing, and overall, the evidence suggests that telemedicine can improve access to care as well as the value of care. However, evidence of the impact of telemedicine is not entirely consistent. Some studies have shown no positive benefits to telemedicine. Clearly, there's a need for continued research in this area, but there's another issue concerning research that I believe needs to be addressed, and that is that many studies of the effectiveness of telemedicine have been conducted within hospitals or large physician practices. So, as a result, our understanding of the impact of telemedicine among small physician practices is much more limited. In conclusion, telemedicine is an important tool for small practices as payers transition away from the fee-for-service model. State and federal policymakers have the ability to facilitate the adoption of telemedicine through policies related to reimbursement and licensing, but expansion should be coupled with oversight to monitor impact. Again, I'd like to thank you for allowing me to appear before you today and share my opinions, and I'd be happy to answer any questions that you might have.
Thank you very much, Dr. McHugh. Our next witness is Maggie Baskul. Maggie is the Community Relations Representative for Next Tech in Lenora, Kansas. Recently, Ms. Baskul was involved in a telemedicine pilot project collaborating with local hospitals and clinics regarding their broadband needs. She is testifying on the behalf of the NTCA, the Rural Broadband Association. Welcome, and you have 5 minutes.
Great. Good morning, and thank you for having me, Chairman Collins, Ranking Member Hahn, and members of the subcommittee. I'm honored to be here today on behalf of NTCA, the Rural Broadband Association, to discuss the use of telemedicine and its possibilities for small medical practices from the perspective of Nextech. Nextech serves over 2,200 broadband customers and has over 2,300 voice access lines spread across a 9,300 square mile area in rural Northwest and Central Kansas. We serve 11 hospitals and 14 clinics, among several other small physician practices. I have worked as the Community Development Specialist for Nextech for the past 4 years. I have a passion for rural communities as I have lived in rural Kansas for most of my life. Most of my time with Nextech is spent working with our communities, particularly our anchor institutions, such as these healthcare providers. Nextech recently focused a pilot project on telemedicine in efforts to promote a greater adoption of advanced telemedicine capabilities. We spent time meeting with each hospital and several of the clinics and the small physician practices in our footprint. Collaborating with these healthcare providers was very enlightening, as we learned of the rather large barriers that they are faced with when looking at adopting telemedicine. Hospitals and clinics are undergoing large changes stemming from the Affordable Care Act and other regulatory changes. Several are still in the process of converting to electronic health care records and looking into new financial challenges. Others share that much of their time and efforts have to be focused toward doctor recruitment, insurance barriers, and other pertinent issues. That being said, however, they are all aware of the importance of broadband and how their access to affordable, reliable connections is significant. We have noticed an increase in subscribed bandwidth for our healthcare facilities even in just the last couple of years. We have several hospitals with 50 megabyte per second connections and higher. Many are currently using it for everyday activities such as off-site backup, checking insurance eligibility, sending and receiving digitalized files, conducting research, and etc. Most of these hospitals are engaging in some forms of telemedicine, generally consisting of consultations from patient to mental health care provider or screen-to-screen trainings and webinars. There are more uses that our hospitals and clinics could delve into. So many of our customers live in areas that are literally hours and hours from the nearest specialist or major hospital. Telemedicine has been, but could be even more so, of a lifesaver for those in our area. Even with healthcare staff time and efforts directed to it, there are other factors that come into play as well. As we've talked about, there is a lack of health insurance reimbursement for care through telemedicine and a lot of questions regarding physician licensure. In visiting with hospitals, there is also a lack of resources showcasing tangible applications or even overall guidance that hospitals can utilize to get a sense of the efficiencies that can be added. There are programs available that these hospitals, clinics, and physician practices can look toward for funding, but so often these programs are overwhelming and can be difficult to navigate through. We do have fascinating ideas and programs that are developing at a regional hospital in our footprint, Hayes Medical Center. They are currently preparing to deploy robots to 4 pilot locations that can effectively transport a doctor stationed at a hospital to a remote area. There, the patient can interact with the doctor through the robot with the use of plugins equipped to conduct diagnostic testing. Possibilities such as these are endless, but seeing these through fruition can be another story. Unfortunately, due to a lot of these barriers mentioned, we haven't been able to move forward with our telemedicine pilot project we began in 2012. Not only are our area healthcare facilities facing these types of barriers, but Nextech is as well. Telemedicine cannot be implemented without an underlying robust wired network. Unfortunately, Nextech has been faced with a number of regulatory uncertainties stemming from the Federal Communication Commission's high-cost fund reforms. Due to the high expense of delivering quality communication networks in rural areas, rural providers need predictable universal service support. However, in 2011, the FCC made changes from what was available to the quantile regression analysis, QRA, which has created great uncertainty in the rural telecom arena. While the FCC has now eliminated the QRA, we have reverted back to the previous methodology. A new Connect America plan for rural telecommunication providers still has not been developed. In summary, we at Nextech are just absolutely thrilled to be able to collaborate with our area hospitals, clinics, and physician practices on current and future ideas and projects in telemedicine arena. However, we must be able to continue to deliver the services that hospitals are currently subscribed to and be ready for the influx of those who will continue to need more bandwidth as they grow and technology advances. Rural America will not realize the promise of telemedicine, however, without a broadband USF that offers carriers the regulatory certainty needed to make network investments and an insurance industry that lacks telemedicine coverage. Guidance is also needed for healthcare facilities to take advantage of all that telemedicine offers. We look forward to working with Congress and the appropriate agencies to ensure these programs work as efficiently and effectively as possible. Thank you.
Thank you very much. Our final witness is Brenda Denman. She is a physician with the Fair Oaks Skin Care Center in Fairfax, Virginia. Dr. Denman is a board-certified dermatologist who has practiced for over 16 years. She is testifying on behalf of the American Academy of Dermatology. Thank you very much.
Chairman Collins and Ranking Member Hahn, as a fellow of the American Academy of Dermatology Association, which represents more than 13,000 dermatologists nationwide, and a past president of the Medical Society of Northern Virginia, I commend you for holding a hearing on how telemedicine can further the efficiency, quality, and access to health care. I'm here today to discuss barriers of implementing telemedicine as a modality of care. Specifically, lack of reimbursement and cumbersome credentialing pose the greatest challenges. Although some reimbursement exists, it is not consistent across payers or across states to allow for proper patient access. Telemedicine is an innovative, rapidly evolving method of care delivery. The Academy supports the appropriate use of telemedicine as a means of improving access to the expertise of board-certified dermatologists to provide high-quality, high-value care. As a physician who runs a small dermatology practice in Northern Virginia, I currently use Dermutopia for the provision of telemedicine. This is a HIPAA-compliant mobile phone and web-based application. Through this application, I'm able to evaluate, triage, and treat both my patients and patients who do not have a primary dermatologist. We're aiming to treat Medicaid patients through Dermutopia. However, there have been delays in ability to solidify funding despite the fact that Medicaid has been approved for reimbursement for telehealth services in Virginia. I have faced several barriers to most effective providing care via telemedicine. While I face these barriers as a physician, it is ultimately the patients, often the most economically vulnerable, that are the most directly affected. The largest barrier, as noted, is reimbursement for telehealth services. Without reimbursement, providers and patients are unlikely to utilize telehealth. The benefits of such reimbursement would be widespread. Telederm can save a patient time missed from work, travel time, and in the correct clinical context allow for timely diagnosis and treatment when face-to-face care is unavailable or inaccessible. While Telederm has traditionally been used to increase access to the remote or underserved areas, it indeed has great potential for serving a variety of patients for dermatological needs. For instance, insured patients in urban areas may face similar access delays or issues as those in geographically remote areas and therefore benefit from teledermatology. I have seen firsthand a number of patients that could have had the consultation done virtually and prevented an onerous trip to the office or to an urgent care or emergency room. An 89-year-old woman who lives alone at home with no family in the area and who would need to be brought to the doctor via wheelchair and transport vehicle may be more easily evaluated via telemedicine. A nursing home patient with dementia who requires a nursing aide and transportation and coordination costs from the nursing home to evaluate a leg ulcer or an early infection could be effectively evaluated via teledermatology. A 2-year-old with severe eczema and infections who cannot get in to see a dermatologist due to lack of access to a Medicaid dermatologist and inability for the parents to transport them during work hours across the city, 2 bus rides away, could be easily evaluated and monitored via teledermatology. Overall, telemedicine provides a modality of care which can expand patient access to medical specialists, such as dermatologists, but barriers to implementation remain. Most notably, issues of proper credentialing and reimbursement exist to varying degrees across states. These barriers impact providers, but ultimately can hinder patient access to care. I, as well as the Academy, appreciate the subcommittee's continued leadership on this issue and look forward to working with you to ensure that patients can benefit from high-quality, timely, and cost-efficient care for telemedicine. Thank you.
Thank you very much. I want to thank all of our witnesses. So far, we haven't had votes called. So at this point, I'd like to yield to Mr. Luca Meyer for his 5 minutes of questioning. Mr. Luca Meyer.
Thank you, Mr. Chairman. Ms. Denman, thank you for your testimony this morning. And I was kind of, as we go through the process here of talking about telemedicine, I'm kind of curious that you're involved in the practice every day. How many more patients can you see? In other words, how much more benefit can it be when you have the ability to do telemedicine here? Is there? I realize every case is different, but I mean just.
Well, I think as she's said, these studies have not been done, but we're anxious to do them, pilots, and to see what the benefits could be. Personally, I think I could see 5 to 10 more patients a day.
Very good.
And that's with the effectiveness of evaluating them through the applications, through the computer, through the details they're provided, because teledermatology is a unique specialty that allows the pictorial view of the disease.
How do you minimize or mitigate the liability situation that you have as a doctor when you diagnose someone and someone else takes that diagnosis and then administers the care? How do you mitigate that? Are you concerned about it at all?
Of course, our concerns are to protect the physician and protect the patient ultimately. It's interesting, a lot of care is already provided via the phone with very little details and with sometimes misinformation communicated through a phone. Whereas with the use of video or store and forward technology, you're getting so many more details and so much more important information that allows you to make a very important triage or a suggestion to advise the patient to come in, to advise the patient to go to the ER. I think that in many ways it protects the physician to have telemedicine as part of their practice.
Excellent. Ms. Baskul, you went at length with regards to the broadband problem that is very prevalent in a lot of the rural parts of our country. And, to me, this is probably the biggest problem I would see, other than perhaps reimbursement, with regards to telemedicine from the standpoint of the benefit it could be to the rural areas, yet with the barrier of the lack of broadband, in some areas it would seem that would be, a huge hurdle. I know I live in the rural part of Missouri, and, I'm barely within a broadband area myself, and so I know that there's a lot of areas within my own district that do not have broadband. So can you speak to that just a little bit about the concerns, how you're working with providers, and what may be some hurdles or some things maybe perhaps that we can help you with to be able to enhance that?
Sure. Well, Next Tech's actually sitting in a very good position as far as the broadband that we're able to offer our customers because of some past RUS loans, because of the broadband stimulus grant that we were able to get. We were able to build out fiber optics and also WiMAX, a wireless technology, to reach several of our customers that were out in a rural area who otherwise had dial-up service. So I feel like we're sitting in a pretty good position where we can continue to work with those. You're always going to have customers who aren't in line of sight of a tower and are down in a draw or have trees surrounding them, and you just continue to work with them and say, what else can we do? Can you look for a unique solution for that? Can you put up a pole or put the whatever might be able to work for them? As far as other companies in other areas, I know that it is a large issue, and I think a lot of maybe investments that would have otherwise have been made at this time haven't been due to the regulatory uncertainty. I believe in the written testimony we have some statistics where it talks about the number of RUS loan applicants that were during the first 3 years of the program versus the past 3, and how those have dropped tremendously just because people aren't certain of it has to be feasible in order to make it work, and when it's uncertain, it's difficult to make that happen.
Thank you. Dr. McHugh, you talked about licensing across state lines as a problem. And I'm sure when you practice across the states, you have to have a license. So when you practice telemedicine across state lines, it's a whole new world there of licensing. Can you talk about the problems and what kind of solutions you may have?
Sure. This is a bit of a challenge, especially where state medical boards have made decisions to limit practice to physicians who are located in the same state as the patient. It really limits competition, and it limits the ability for the patient to seek care outside of the state lines. And there are several different approaches that could be used to address this problem, anywhere from federal approaches where the federal government decides that we're going to have a sort of a national leadership in terms of licensing of telemedicine providers, to keeping this a state responsibility and having states come together through some sort of interstate agreement where one state will recognize licensure in another state.
Is there a movement along that line?
There has been some advocacy along that line, but there hasn't been a whole lot of groundswell of support. I don't believe that many states have signed on to that yet.
I see more of my time. Thank you, Mr. Chairman.
Thank you, Mr. Luca Meyer. At this point, I'll yield to Ranking Member Hahn for her questions.
Thank you, Mr. Chairman. I really appreciate all of your testimony. I learned a lot listening to each and every one of you. And some of my questions were already asked by Representative Luca Meyer, but I was thinking along the same lines. One of the things comes to my mind is patient privacy. And I was going to direct this to Dr. Rubin, but any of you might want to answer that. There's been a high-profile case lately of a doctor who was found secretly videotaping one of his patients in the exam room, and I think that just sort of sends fear through, I know women particularly. What would be your take on who should design the protocols for processing, sending patient information, and can or should the federal government be involved in helping to regulate telemedicine to ensure patient privacy?
It's an excellent question, and certainly all HIPAA privacy and security regulations apply to telemedicine providers as well. So I don't know that we necessarily need to regulate even more. The American Telemedicine Association has developed practice guidelines and standards, and I believe they should be sufficient, but it is a matter of training, working with industry, working with the provider community, working with the Federation of State Medical Boards so that everyone understands where we are currently, and then educating providers themselves about the appropriate use of telemedicine.
Do any of you have any comments on that?
Yeah, I think that if you go to the ATA meeting, American Telemedicine meeting, you see that HIPAA compliance and security is utmost importance. The technology is there. The enthusiasm of the scientists that come to these meetings is there. And I think that what we may not realize is already a lot of information is communicated in non-HIPAA compliant ways. And so we need to actually channel the physicians and the healthcare providers to use these very secure systems that have been developed, because I think ultimately that is a risk for the patient, but it can be overcome.
Now, Dr. Denman, you talked a little bit about how it could work in the world of dermatology, and you also mentioned possibly a patient in a nursing home with Alzheimer's. I was wondering how the rest of the doctors could comment on what do you see as good cases for telemedicine, and are there ones that, of course, would not be ever able to be accommodated by telemedicine? I would just like to hear a few more. What are the actual cases that you think would be served well by this?
Well, I'll just jump in and say that when you think about the functionality and the capabilities of telemedicine, they cover such a broad range of functions. You can have a consultation, you can diagnose, you can do remote monitoring, you can even have physician mentoring. And so when you think broadly about the scope that telemedicine covers, it's really hard to imagine, a specialty that couldn't be aided by telemedicine. I mean, you can even think about things beyond traditional specialties. So, for example, I teach a graduate health policy course, and one of my students is an emergency physician who wrote a terrific paper on the use of telemedicine for EMS, emergency medical services. So you can imagine an ambulance even going out into the field and getting really expert advice about whether to transport a patient and where to transport a patient.
So I don't think you even need to imagine it because it's already here. So in our program, we are providing services in more than 45 different subspecialties of healthcare. We do rely on our clinicians as to their comfort level of providing the service. We have protocols in place that have been developed with the providers to be sure that we're doing the right thing for the right patient at the right time. The American Telemedicine Association has many dozens of special interest groups that work with the specialty societies. If you want some use case scenarios, high-risk obstetrics telemedicine, cancer services. We do screening for diabetic retinopathy, acute stroke care. In my own specialty of pediatric cardiology, I can use an electronic stethoscope and read an ultrasound in a nursery where there's a baby that may have low blood oxygen. It is pretty much, as Dr. McHugh said, diverse across all the specialties.
Thank you. And I know my time's up, but I will say I read something which none of you have actually touched on, was the doctor-to-doctor use of this. And I was reading an example of a doctor who said, alone at night, kind of dealing with a case, no one was around, and the opportunities of sending to another doctor these kinds of videos or pictures and having a consultation with another physician. Thank you very much.
Yeah, thank you. I'd like to yield now to Mr. Kaufman for 5 minutes.
Thank you, Mr. Sherman. Thank you all for coming here to testify on telemedicine, and obviously my hope, and I think the hope of many members of Congress, is what can we do to reduce cost and expand access to health care. So I'm wondering if you all could elaborate on I think 3 things. Number one, to what extent have we what are the frontiers for telemedicine in terms of what can we still exploit in terms of opening access, lowering costs? And then the second part, what are the impediments to doing that? Are they cultural within the provider community, or are they regulatory in nature? And then I think the third would be just an idea in terms of what it could mean to our healthcare system if we could advance telemedicine further in terms of opening up access and reducing costs. Dr. Rubin, why don't we start with you, please?
Thank you. I think the frontiers are the delivery of care in the non-traditional environment. So in the workplace, potentially, when people are traveling, many in the home. We have a lot of cost savings data actually that are available. And as an example, in our own program, I mentioned the high-risk obstetrics telemedicine program. We've reduced preterm delivery and reduced days in our NICU by 39%. That's a huge cost saver for our state Medicaid program and for the payer community. In stroke, if you can provide timely access to a stroke neurologist and appropriate use of clot-busting medication, that saves huge disability, saves lives, and saves nursing home care. Nursing homes are a wonderful place because of the challenge of transporting patients, the cost of the Medicare program. Remote patient monitoring in the home, we've done about 650 patients we've supported after discharge from the hospital, and we have reduced readmission by 50% in those patients who would have bounced back. So those, again, cost savings. So the frontier is being broader in terms of our look, see, and how we can do it, and eliminating some of the regulatory barriers that have limited providers from utilizing these opportunities.
Great. Dr. McHugh?
Mr. Kaufman, you had asked whether the barriers are more public policy related versus cultural, and I would argue that they're both. There's certainly a lot that policymakers can do to expand the use of telemedicine, but I think the cultural barriers are an important one that we haven't really touched on yet. Work in quality improvement that has shown for decades that changing physician behavior is very, very difficult. But one thing that is very much in your purview is to change reimbursement policies. And as I mentioned, my personal opinion is that expanding telehealth coverage in value-based purchasing programs, it would be, a natural next step for that, because under value-based purchasing programs, physicians and hospitals are incentivized to provide high-quality care at the lowest cost. And in some cases, we know that providers don't have the flexibility to use telemedicine under these programs, even though it could be a very useful tool to improve the value of care delivered.
Great. Ms. Baskul?
Yes, I would also like to touch on those same lines. The frontier in our rural area seems to just be, let's get this started. Let's move past just the face-to-face consultations they're currently having with, most of it's focused on the mental health side. We have a shortage, I think, of mental health, psychologists, psychiatrists, that sort of thing in our area. So a lot of times the hospitals are using kind of like an ITV sort of setup for those means. So I think we just need to get past that. But I think one of, like you mentioned, cultural, one of the biggest barriers is we have an aging population, and that is both doctors and patients. So doctor recruitment will be very interesting as they're trying to get some younger doctors in to focus on maybe they will have a want or a desire to bring in some of this technology, and then also helping our customers understand broadband and bring that into their lives a little bit more so.
Dr. Denman?
Yes, I'd like to focus on the cost-saving aspect of telemedicine. I really think that if we look at our rehab centers and nursing homes, how we could bring the care to the patient instead of bringing the patient to a office or an emergency room without knowing where they need to be. For example, if we bring the care to the patient, we can evaluate a leg ulcer or an early infection more quickly and get the care implemented so they do not end up a patient that's hospitalized. Secondly, I think one of our biggest patient populations is our obese and diabetic population that can be monitored through teleophthalmology. They can be monitored through teledermatology. They have leg ulcers are, again, a big cost to the healthcare system, as well as the other complications of diabetes. So I feel that we can see this in many specialties, that we bring the care to the patient and the system will save money.
Yeah. Well, thank you all for your testimony today, and for working in this frontier. I think that it has such promise in terms of opening up access and lowering cost and hopefully maintaining, if not improving, quality. Madam Chairman, I yield back.
Thank you.
Chairman, I yield back.
I like Madam Chairman.
Thank you very much. Well, we've timed this fairly well. They've called votes, but we still have some time. I'd like to maybe ask a few questions to close this out. On the reimbursement issue, I mean, we've talked a lot about Medicare and Medicaid. Dr. McHugh, what about the private insurers? start with the basic question. Do they make the decision themselves whether they reimburse? Could you have one insurance company in an area saying we will reimburse our doctors for telemedicine, and yet another private insurance company saying no, or is this a statewide issue?
So insurers do make the decision themselves. However, they have to follow state laws regarding mandated benefits. So some states have laws saying that insurers who offer coverage in their state must offer that particular benefit.
So you could have, though, a cutting-edge company saying, we're going to do it. So, so it's the insurance company can do it. A state might mandate it, but in the case of where I think there's 20 states, as I understand it, about 20 states that have a reimbursement policy, but that leaves 30 states without one. So in those states, a private insurer could decide it's just good business for them.
Absolutely, and we see many insurers, being swayed by the evidence and going far beyond offering coverage for the services that are mandated. They realize that it makes good business sense.
So, Ms. Baskul, in some rural areas, and certainly mine, I have a very rural area, we have 25 to 50,000 households that don't have broadband coverage, and part of that gets back to the definition of what's an underserved area and not. What about, have you seen any cases where a patient, somebody could have a small, call it office setting, clinic setting in a rural area that has broadband, a patient could actually drive 5 miles there and connect at that point to a physician that's 50 miles away, almost like a call center? Have you seen anything like that?
The most that we've seen as far as that goes is on the mental health side. And again, I think it goes back to some of the closest psychologists are, an hour and a half, 2 hours away, where in my area, I think a lot of people are used to driving and it's maybe not as bothersome to them to go to see their doctor physically rather than online. I do think it also goes back to the aging population and what their comfort level is. I think that there are a lot that are just more comfortable being there physically, but as we have a younger population coming back to our area, I think that is starting right now. We're seeing a trend where some younger people are moving back to their hometowns. I think as that continues, I think that comfort level will rise, and maybe we will see more of that in the foreseeable future.
So a question on maybe the mental health piece more than any. We have college kids that may be seeing, for various reasons, a mental health professional at home. They've developed a relationship with that person. They go off to college, maybe they're back and forth. It would appear that would be a very appropriate use. You can't just say to a college student in another state, because of licensing procedures, you have to start a new relationship. Would anyone like to comment on that piece?
That's absolutely a perfect use case and an example why the lack of licensure portability can be a challenge. That provider that's caring for that student would have to have a license to practice medicine in that state. Now, the Federation of State Medical Boards is moving forward with an interstate compact to try to expedite the licensure process, but it still is going to be time-consuming, and we look forward to seeing how quickly and how expedited this process will be. But your example is a perfect example about why we need some broader vision in that regard.
Would any of you like to comment, Dr. McHugh? Is that a proper role perhaps for the federal government? I think some of us would say, we defer to the 10th Amendment and states' rights, and I know I, for one, am very reluctant to ever step in with a federal policy or support a federal policy that tramples on states' rights. But, we seem to be in this telemedicine quandary of 20 states have reimbursement policies, 30 states don't. The licensing issue, it was brought to bear recently with a football physician who was treating his team in another state and the player sued him. That's brought that to a forefront. Is this one where perhaps some federal statutes could give some limited coverage?
I think so. I mean, certainly the federal government coming in and taking over this responsibility does introduce some issues with federalism. However, as a consumer and a parent, I want high quality care, and whether it's the federal government who shows leadership or state governments who show leadership, if the states aren't going to act, I would like to see the federal government act.
I would also like to point out that there are 50 different state Medicaid programs with all different regulations as well. And that is a major challenge for our patients, especially as we see more insured patients under the Medicaid program. So I would certainly be supportive of greater oversight when it comes to Medicaid programs and telemedicine as well.
I mean, it almost seems like you could have some exceptions for existing patient relationships, you know, to avoid that. I mean, I'm from Western New York. We have a lot of folks, a lot of our older population goes south for 3 months to Florida. And there's another case. They have the relationship. It's not a New York doctor poaching in the Florida area for clients, but rather an existing client relationship, much like the college student and so forth. Do you ever think you could see something where there'd be protections and or licensing granted to existing patient-doctor relations different than a new patient? Is that even a possibility?
I think that that's very doable, and especially to have, some of the states have a specific telemedicine license that doesn't give you full access, but you do have the ability to treat patients across lines. And I just wanted to remind us that there are many states that there's a huge shortage of pediatric specialties, such as pediatric rheumatology and endocrinology. So there are whole states that don't even have one pediatric rheumatologist. I think those people should have the ability to have a telemedicine consult, even if there isn't an existing relationship.
I think our time has come to an end. I have other questions, but I think what we've seen here is common sense. You know, we like to think that common sense should carry the day. And technology has now moved us to a place we can better serve an aging population or in a rural population where we know there's going to be a shortage of doctors. There's already a shortage of specialties. There's many mental health professionals that are doing concierge medicine. They don't even take insurance. I know in the dermatology professions especially, you know, you can wait 18 months to go get they call it an annual skin check, but they should now call it an 18-month skin check. So, I mean, I think common sense says we need to move this forward. If a doctor doesn't get paid, they're not going to participate. So reimbursement, the licensure issues are, no one wants to be put in a position of not complying with the laws relative to their license or in some cases their own liability insurance policies. So what our purpose today, and I think we accomplished, was just start a discussion. I think this is only the second hearing in Congress on telemedicine. It's messy with state laws. It's messy with Medicare and Medicaid and different practices and existing relationships and so forth. But if we don't start the discussion at some point, and we're seeing a hodgepodge of things move forward state by state. So again, your testimony was quite timely. We appreciate all of your comments and hope that this discussion is helpful to those of us who just want to move forward in a common sense direction. I ask unanimous consent of members that we have 5 legislative days to submit statements and supporting materials for the record, and with no objection, that is so ordered. The hearing is now adjourned.